Okay, let's dive into this topic. I cannot tell you how excited I am. Um, the topic today, pediatric allergies. Introducing solid foods to your baby can be exciting and stressful and fun and confusing and everything else. And you want them to try new foods, and you also don't want them to choke. So there's a lot of different things going on there. And then the subject of allergies comes up, and that's a whole other animal to deal with. So my son Hunter, if you've been listening, is allergic to eggs, pistachios, and cashews. And we found out that he was allergic to eggs when we introduced them to him, and he ended up in the ER. And I was just clueless about the whole thing. I'd heard of allergies, but I didn't know how to handle it. And I kind of wish there was a podcast like this for parents like me. So I'm really happy that we're doing one today. And also, I think that this is important for the parents of children without food allergies to listen to as well, because then they can understand the seriousness of it, why there are certain restrictions in classrooms or parties. And please pass this on to your fellow parents. Prior to having Hunter, I had a friend who had expressed frustrations about bringing a birthday snack in for her son to the classroom. And she said, gosh, back in our day, we could just bring a box of donuts, and now everybody has food allergies and has to be wrapped. And I laughed about it because I thought, oh God, that's so frustrating. Now, as the parent, I completely understand and respect those restrictions. So I think it's good for everyone to listen to this.
Absolutely. So according to the Mayo Clinic, food allergies is an immune system reaction that occurs soon after eating a certain food. And even a tiny, tiny amount of the allergen can cause this triggering sign and symptom, such as a digestive problem, hives, or swollen airways. In some people, a food allergy can cause severe symptoms or even life-threatening reactions, known as anaphylaxis. Food allergies affects an estimated 8% of children under the age of 5 and up to 4% of adults. And while there is no cure, some kids do outgrow the food allergies as they get older. And I know that that has been the case for you too, Jess, right? With some of them?
Yeah, with hazelnuts, he outgrew it. He's only 16 months. So it's interesting. It's a variable thing. I would not want to be an allergist, Dr. Liebhaber, because it is a moving target. And I appreciate the professionals in this field. To continue, it's easy to confuse a food allergy with a much more common reaction known as food intolerance. And while those are bothersome, food intolerance is a less serious condition that doesn't involve the immune system. So today we're going to focus purely on allergies, so us parents are more informed and have more tools in our tool belts to help our little ones. So let me introduce you properly to our guest, Dr. Myron Liebhaber. After graduating from medical school at the University of Arizona, Dr. Liebhaber completed his medical training at Stanford University Hospital, followed by a fellowship in allergy immunology and pulmonary diseases at Stanford. Over the past 40 years, he has pursued his career as an allergist at the Samson Clinic in Santa Barbara, California. His major interest has been in the treatment of allergic disorders, asthma, immunodeficiencies, and cystic fibrosis. He has served as a clinical associate visiting professor at UCLA and is the founding medical director for Camp Wheeze, an educational experience for children with asthma. With a great interest in clinical research, he's published many articles and abstracts in the area of allergic, immunologic, and pulmonary diseases. He has won numerous prestigious awards and also has served on the board of directors of Cottage Hospital of Santa Barbara, the American Lung Association of Santa Barbara, Ventura Counties, and is a past president of the Santa Barbara Medical Society. With that, thank you so much for joining us today, Dr. Liebhaber. We're so happy to have you here.
For having me. I'm glad to be here because it's an interesting topic. There's a lot of knowledge about food allergies, but a lot of misconceptions, and maybe we can resolve some of those today.
That's great. Yeah, I would love to actually, at the end, if we don't cover the misconceptions that you feel, please let's bring those up because I don't want to miss that. So let's get started. What are the most common food allergies in children and adults, really?
Well, I divided it up into 3 categories. There's baby food allergies, there's toddler and older children food allergies, and adults. And for babies, the most common food allergy would be dairy and egg. For older children, toddlers, and even into the teenage years, the top two are peanuts and tree nuts. And that's pretty much true with adults, but then we add in seafood and sesame and soy and a few other foods that accumulate throughout a lifetime. Our concern is that it seems to be increasing. Over the past 10 years, food allergy prevalence has increased by about 18%. And truth is, we don't know why. It's a mystery. We do know, however, that over time, a lot of people will lose their allergies. You mentioned earlier that 8% of children have allergies. That's 1 in 13 children, but that number drops to about 4% in adults. So obviously, people are losing their sensitivity as they get older. Now, the other big misconception is a lot of people who have self-reported food allergies without any testing or documentation are really not allergic to the food, especially in children. And they've done a study, a very interesting study in New York, I believe, where they took children who were stated to be allergic to a particular food. They put them in the hospital, actually gave them that food that they thought they were allergic to. 75% were not allergic to the food. So what's going on here? I have my pet theory. One is that children get a lot of viruses, and with the viruses get a lot of rashes. And of course, you're eating all the time, so the food always gets blamed. And it may not always be the food. It could be something else. So we know as allergists that 75% of perceived food allergies are not real allergy. And it's a shame because, it can really affect the lifestyle. It can affect their social interactions. It can affect school. So it's very important to have very strict criteria. Now, one other thing I do want to mention, and that is there's a big difference between people who are diagnosed with food allergies based on testing. That's called sensitization, and true allergy. So a lot of people will test positive to a particular food, but they can eat that food and they're fine. They're fine. So there's a lot of false positive testing. And what's going on here? There's a lot of foods that children are exposed to that can cause rashes around their mouth, for instance, and that's called topical sensitization. Just this week, I saw a child who had a rash around his mouth when he ate cinnamon. Well, cinnamon is a skin irritant, and when the mouth is wet, which a lot of kids are, and you're exposed to cinnamon and it sticks to your skin, it can cause a rash. But that's not true allergy. That's maybe sensitization, but it's not true allergy. So that's where a lot of the confusion comes in.
That's, gosh, you touched on so many different topics there that I feel like I'm so grateful to have that out there because, I know people who in adulthood feel that they're allergic to something and carry an EpiPen, but they've never gotten tested for it. And so that brings up a whole other thing. So I'm grateful that we're kind of talking about the actual testing and why it's important to know if it is a sensitivity or if it's a true allergy, as you were saying. So,
big difference.
So when it comes to introducing allergens into a child's diet, how do you suggest doing so? When do you suggest doing so? And also, with the topic of eggs, should you introduce egg yolk and egg white separately?
Okay, good questions. So we'll divide up children into high risk and low risk. So a high-risk child typically has eczema and other allergies during infancy, and a positive family history of allergies. That is, one or both parents have allergies. That's what we call a high-risk infant. And those infants, we do have to be a little careful. There was a recent study in Japan, it's very interesting, that looked at the introduction of cow's milk during the first 3 days of life. All these infants were breastfed, but then they were supplemented. Half of them got cow's milk, the other half got some kind of elemental form or even sugar water. And it turns out that first 3 days is very important, more important than we thought. So if they were introduced to milk within that first 3 days, and they tested them at 5 months and 2 years of age, they had a very high incidence of milk allergy. However, the infants that were breastfed, and by the way, breastfeeding is terrific if you have allergies. If they were breastfed and not introduced to dairy at all in the first 3 days, they had a very low incidence of milk allergy at 5 months and 2 years of age. So that first 3 days, and usually that's in the hospital or in a nursery, those are very important days. And so we're paying a little bit more attention to that. Now, let me get back to your question, Jessica, and that is, when do you introduce solids? So sometimes an allergist wakes up and realizes everything you've been telling people for years and years, and I've been in practice for 45 years, has been wrong. And that's what we're discovering now. We used to say, if you have a high-risk child for allergies, you should wait and introduce high allergenic foods later, beyond 1 year or 2 years of age. Again, now we realize we've been telling everybody the wrong thing. That if you are at high risk, the recommendation now is to introduce egg, and I like separate yolk and white, before 6 months of age, preferably 4 months of age. That's totally different than what we've recommended in the past. And same with peanut. And how we discovered that is very strange. To make a long story short, a lot of children living in Great Britain have peanut allergies. Typically, they weren't exposed to peanut early on. You compare that with a population in Israel where the teething biscuit called boba had peanut in it. And they were introduced very early because of teething, and they didn't grow up to have peanut allergy. So it turns out now these are just high-risk infants that I talked about earlier. If you introduce peanut and egg early on, they don't grow up to develop peanut and egg allergy. So it's a little bit different thinking than the way we were thinking when I first started practice. Now, let's switch to your question, when do you introduce solids? Again, if your child is not at risk, really, you can follow your pediatrician's recommendations. My background is pediatrics, so when I was practicing pediatrics, which is many years ago, we would always introduce the vegetables first, because if we actually introduced fruits, they got used to the sweetness of the fruit and then wouldn't take the vegetables. So most pediatricians, and really follow your pediatrician recommendations. Our pediatricians are smart people. They've dealt with this also. And so they will oftentimes recommend vegetables and grains, and then later fruits and meats, according to any schedule you really want. And breastfeed as long as possible, a minimum of 6 months. I think that's the accepted recommendations. But again, your own pediatrician's thoughts may differ. Follow your pediatrician's recommendations.
I know we talked about different like rashes or different things like that, but If I'm a parent and I don't know if my child is high risk or not, whatever, or there's no history. Like, for example, we actually have no history of allergies, food allergies in our family, but my son did have eczema, so that should have been a clue.
Okay.
What are different ways that a parent can tell that their child has food allergies? How does it present itself, I guess?
Well, first of all, let's talk about the high risk foods. We call them the big eight, the big eight. And that's, I got to count on my fingers here: dairy, egg, peanut, tree nuts, soy, wheat, fish, and sesame seeds now are becoming popular. These are the foods that you have to be alert about. And so you can introduce these foods, especially if your child is at low risk for allergies, really anytime your pediatrician recommends. But if your child's at high risk, these are foods you have to be careful and you have to watch. Now, when it comes to food allergies, it doesn't take a lot. We're really talking about molecules of food. So for instance, in your child, a molecule of cashew or pistachio can cause a rash, and it usually happens right away within an hour or two. And that's usually not a mystery because it happens right away. And then you have an aha moment. You can say, oh, I fed him a bagel with sesame seeds for teething. Stale bagels are great for teething on, by the way. And then he developed a rash right away. And that rash, when it comes to allergy, is usually itching and hives. And so those are the two things that we look for. Hives, are raised welts that it could occur anywhere on the body. And that usually occurs within an hour or two after eating the food. Did I answer your question?
Oh, 100%. Yeah, 100%. Oh, Angie, you look like
What about like watching what happens with the diapers and the output for a baby? Because I've heard if you see like mucus or blood in the diaper or something, that indicates a food allergy. So can you kind of provide some education on what we're seeing in the diaper?
Yeah, it's important, but don't get too focused on that.
Okay.
Said that, I will tell you there is a syndrome that is not allergy related called FPIES, food protein induced enterocolitis. That's not an allergy. That doesn't involve the allergy antibody IgE. That involves other mechanisms. And what happens to the stool is if a child has FPIES, they get tremendous diarrhea. It could be bloody diarrhea. I've had children hospitalized for that, even though it's not a true allergy. It's a sensitivity to a particular food. And it's really strange foods, by the way. It's not the common allergy foods that we see. In FPIES, we see children with allergy to things we never think of, like grains, like barley. I've seen it with rice. And, we think of rice as a very hypoallergenic food, but not if you have FPIES. So that's another end of the spectrum, but it's not the allergy end of the spectrum.
regarding FPIES, our allergist had mentioned that, it's extremely rare, but I think it was May of 2020 or something, you guys had 12 cases of that in 1 month. And that's something that's also rising and people are seeing a lot in the allergist office. Is that correct?
That's absolutely correct. Again, for reasons we don't understand. And it's good to be aware that occurs, but don't worry about it too much. In other words, my whole mantra here is relax and enjoy your kids and enjoy your meals together. Most people don't have FPIES. It's very rare. A lot of people don't even have allergies. Very rare. And so we have to be aware of those, but I wouldn't recommend focusing too much on that. It's very rare.
That's fantastic.
I didn't tell you why people have allergies. Do you want me to do that?
Yes, please.
Here, I'm asking my own questions.
No, that's great.
So we know that in people with allergies, the familial type allergies, that they respond to the world in a different way. It's called a Th2 response or an allergy response, in which their thymic-derived lymphocytes, which is a blood product, looks at the world and makes an allergy antibody. And that antibody is called IgE, globulin E. And we know that if you have an allergic predisposition, you make more of that IgE than people who don't have allergies. And if you look at the adults, the parents, they have high levels of IgE. And it's that IgE, when it meets up with a foreign protein, and those foreign proteins are described in biochemistry in 4 different groups. I won't tell you what the groups are because it's confusing. Once you react to those proteins, and so it's protein that causes allergy. It's not sugar, for instance, like lactose intolerance. So it's a protein, and primarily called storage proteins. Once the IgE reacts to those storage proteins in plants or animals, it creates an allergic reaction in which histamine is released. And that's why we take antihistamines to combat that histamine release. So that's why a lot of our patients have Benadryl at home as a pediatric syrup to give to their children with allergies to combat the histamine that's been released. We use antihistamines. So that's the basic biochemistry and the basic genetics behind food allergy.
So helpful. I know I'm skipping around a little bit, but on the topic of Benadryl, on the box, it says very clearly, do not give to a child under 2 years old. And that was very confusing for me because when Hunter had an allergic reaction, I didn't know how much I should give in a dose. And so I had called the on-call thing since it was a weekend, and they said, just take him to the ER. And then I found out later that 2.5 mLs would have helped or whatever, but I want some clarity with regards to that. Why do they even put that on the box? Is it to protect themselves? And what is appropriate?
Okay, well, as you know, to put a pediatric dosage on a box, they have to do the research. I think probably more than 50% of the drugs that we prescribe as pediatricians, the research has never been done and probably never will be done. But over the years, we've gotten used to using these medications in children, and we're comfortable using it in spite of what the label says. And Benadryl is a perfect example of that. I love Benadryl. If I was a pediatrician, I would have every parent have a bottle of Benadryl at home. I mean, for treating anything. I mean, for treating food allergies or bee stings or rashes or sunburns or whatever. It's a terrific antihistamine. And they make a cherry flavored pediatric syrup that's terrific. You'll have no problem getting your kids to take it. And under a year of age, under 2 years of age, we recommend a small dosage, like 1/4 teaspoon. We think that that's safe. It's a good antihistamine. It's an effective antihistamine. Being that it's in liquid form, it works right away. So we have no hesitation in prescribing that.
So you talked a little bit about allergies being like why they present themselves and why they occur, but is it primarily genetic?
It is very genetic. Now, here's the catch though. So if you're an allergic parent with an allergic child, the chances are pretty good that your child is going to have allergies as well. However, the catch is what you're allergic to isn't handed down in families. That allergic predisposition is, but not the specific thing. The specific thing that you're allergic to depends on what you're exposed to. Let me give you the classic example of penicillin. A lot of children are born with parents with allergies. And when they're exposed to penicillin for a strep throat or whatever, they're fine. But after repeated dosages of penicillin, they may go on to develop a penicillin allergy. Now, let's just assume that somebody never had penicillin, took it for the first time. The chances of them having an allergic reaction aren't very good, even if there's a family history. So specific allergies are not inherited, but the allergy predisposition is. Did I confuse you?
No, that clarified very much so.
Okay.
Yeah, I had asked certain friends and family members if they had questions for you, and that was something that my sister-in-law was curious about, because my brother is allergic to shellfish. So they have been waiting to introduce shellfish to their daughter until the 3-year-old mark, and she wanted to know, is that good? Is that bad? I mean, everything's changed over the years. She doesn't know if she should or if she shouldn't.
Well, again, those types of allergies aren't handed down. So they could be exposed. Now, my question is, most little kids don't like shellfish. I wouldn't be that anxious. I mean, it's not part of the regular diet. I wouldn't be that anxious to make a 3-year-old eat shellfish, because most of them won't and don't even like it.
That's good advice.
It's not a big issue.
And then as far as the reactions of allergies, what we're primarily looking for is like a rash or hives, correct? And then can you also talk about the severity of anaphylaxis and what to immediately look for then, and how quickly we need to get to the ER, et cetera?
Yeah, anaphylaxis is a whole different thing. It's funny, the word, you know what the word anaphylaxis actually means? Ana, without. Phylaxis is Greek for protection. It means without protection. But really what's happening is exactly the opposite. For anaphylaxis to occur, the child is making too much of an immune reaction, too much IgE, too much of this Th2 reaction. So they're really overreacting. And anaphylaxis, by definition, involves 2 or more systems. So for instance, hives is not anaphylaxis. Hives with wheezing is anaphylaxis. Hives with low blood pressure is anaphylaxis. Hives with airway swelling, that's anaphylaxis. My point here is when 2 systems or more are involved, that is a medical emergency. That's when, if you have an EpiPen or AviQ, you should use it, but that's not enough. You still have to go to the emergency room. It just buys you a little time to get to the emergency room. These are serious reactions. And fortunately, in children, it's very rare. And death from anaphylaxis in children is almost unheard of. It's less than 1%, probably around 0.5% of the entire population. So very, very rare, but the potential is there. And that's why you have to go to the emergency room if you have anaphylaxis, that is 2 or more systems involved, and had to use a emergency device. Now, while we're on emergency devices, can I show you a couple?
Absolutely.
Yeah. Go for it.
Okay. So here's the standard one. I'll hold it up to the camera. This is called an EpiPen. An EpiPen is a self-injectable adrenaline that you can get in the emergency room. It has a little safety guard on it, and you pull that safety guard on it, and you put it on your child's external thigh. You hold it down. A needle comes out, injects adrenaline into the muscle It can't go underneath the skin. It has to go in the muscle. And you count to 3, 1, 2, 3. Very easy device to use. A lot of schools have these. But now there's something new. And this is why I get excited. This is called AviQ. Can you guys see that okay?
Yeah, that's what I have.
Great. So AviQ is not spring operated, it's gas operated. And it talks to you. It tells you exactly what to do. Here, I'll take off the safety.
This trainer contains no needle or drug and is for training purposes only. Do not use this trainer during an allergic emergency.
So,
If you are ready to use, pull red safety guard down and off of this trainer. Place black end against outer thigh. Then push firmly until you hear a click and hiss sound and hold in place for 2 seconds.
isn't that nifty? I love that.
Black end against outer thigh. Then push
So
firmly
it
until you
even
hear a
even
click
nurses,
and hiss
even
sound
people,
and hold
teachers
in
in
place for
classrooms
2 seconds.
should be able to use it if they could follow
Black end
the
against outer thigh.
instructions. Each kit, either EpiPen or AviQ, usually come with 2, because sometimes you need more than 1 if you're having a bad allergic reaction. You wait 15 minutes and you can use it a second time if you're still having symptoms. Wonderful devices. I love these devices, and has really changed the way we practice, because we still have to take the children to the emergency room, but now we have a little time. Now, this brings us to another point, and that is, if anaphylaxis is occurring, the earlier you treat it, the less severe it's going to be. So I have a lot of patients say, I think he's having an allergic reaction, but I'm not sure. Should I use my pen? You know, if I'm not sure, I say use the device, ask questions later. So the only bad outcomes that I've ever seen are people who waited too long before they use the EpiPen, which, by the way, is adrenaline. And adrenaline combats that allergic reaction very quickly, much quicker than, say, Benadryl. So that's why it's important to have it and to use it. And let's just assume the worst. Let's assume you used EpiPen and your child really didn't need it. No big deal. Very few side effects from adrenaline. It speeds up your heart a little. It's about it. And all those side effects wear off in 15 minutes. But it can be a life-saving device. So I always say, if in doubt, just go ahead and use it and ask questions later.
That's very important advice. And I want to bring up something. Sometimes my allergist and I have discussed this. Sometimes it's one parent that goes to these allergy appointments and the other parent, let's say, is working or whatever. And very often it's common that a child can have an allergic reaction, and the parent who does go to the allergist is taking it seriously. Maybe the other one is going like, oh, it's just a few hives, it's going to get better or whatever. And then they wait, or they wait too long or whatever. I've heard this quite a bit, and that's why I think it's important to just say, trust the allergist's advice in that time is of the essence. And if, like he said, if it's more than one system, if it's hives plus vomiting, if it's hives plus whatever, it's better to use that EpiPen right away. Trust your judgment. I had to use it once, and I was really on the fence about it because I felt like, I mean, he's really got hives. And I know he had this egg, which was an accident. And he threw up twice, but I mean, it wasn't a lot, maybe just a little spit up, but I don't know. I'm glad I did it, because I know it was the right decision. And, when you give the EpiPen, at least in my case, maybe this isn't the usual experience, but I gave it to him and it was like immediate relief. He went from this huge, his whole body was all red. It was like on fire with like a giant hive. And then you give him the EpiPen and it was like, shh, and he was clear of all that. And And also I do want to mention too, he was in a fantastic mood. He wasn't sick. He wasn't hurting. Both times he's had these life-threatening reactions. He's clapping, he's smiling. So, people can think, oh, he's fine, he's fine. But it was a very serious thing that we had to take seriously.
Great. You did the right thing. I'm proud of you, Jessica.
Oh, thanks. It's because of Dr. Chang in your office who basically stressed the importance of it. And also that AviQ trainer is phenomenal because in the panic of the moment of like, I don't know what I'm doing, you open that thing up, you saw it takes 15 seconds. They remind you, boom, it's done. And it's very simple. I do want to mention one thing too for our listeners regarding the AviQ pen. And I don't know what your situation is, but I do know for my situation, insurance didn't want to cover it. The couple times that I've had to get it, and those things are like $700, and I was frustrated because I'm like, this is like life or death here. Like, obviously, I need this for my child. And both times, our pediatrician was able to work with the representative from AviQ for a manufacturer's coupon, and we had to just be persistent about that. So please, if that is your case, please look into that because it's a big expense and that shouldn't really get in the way of protecting your child, personally, I think.
Well, no, absolutely. And they have these pharmacies now that I call them mail away pharmacies. For AviQ, there is a mail away pharmacy. I'll tell you their name. I don't mind. It's called ASPN. And it's a great pharmacy. We can email the prescription. They'll send it to your house. Sometimes my patient's been getting it within 2 days, and they will oftentimes fight with the insurance companies. They will get the authorization. They'll do all the work, getting it authorized and getting it paid for. So that's the other beauty of these mail away pharmacies. They're really good. I will say one thing, and that is when we send it in, we have to give them your personal telephone number. And then they will call your personal number and make sure it's okay to mail it to your house. A lot of my patients, when they get those calls, they think they're scam calls and they don't answer them. And then they don't get the device. So my advice is, they usually call right away, is to answer the phone and give them the green light to mail it to your house.
That's really great advice. I will look up that ASP. You said ASPN?
ASPN pharmacy, yes.
Yeah, because personally dealing with pharmacies for an EpiPen was a nightmare on several occasions, nightmare. So I appreciate you sharing that with our listeners as well.
So I'm going to touch on something here that you brought up, Jess, just with like the apprehension of administering Benadryl or the EpiPen or Tylenol when they're teething or whatever is going on for your kid. And let's say that you are starting to introduce like an allergen to your baby, you notice something starting to happen, when is it appropriate to do that? Like, should I start with Benadryl first and then see how it goes? Or should I just do the EpiPen? You know what I mean? Because I would be wondering those management things in my brain about what to do when or what steps to take. And we often are just like apprehensive as parents to give medication sometimes. So can you talk a little bit about those steps?
Well, first of all, when it comes to anaphylaxis, there's only one drug that works, and that's the EpiPen. So even though we recommend Benadryl, really the Benadryl doesn't really help anaphylaxis that much. It's really the EpiPen. So keep that in mind. Having said that, there is another allergy syndrome we haven't talked about called protein food syndrome. Now, there are, or pollen food syndrome, excuse me. These are people who have what's called oral allergy. Oral allergy is a little different than anaphylaxis. Oral allergy is when you eat a food and your mouth gets itchy and kind of breaks out. Your tongue might be a little irritated, might even swell a little bit. Your lips will swell, but that's not anaphylaxis. That's called pollen food syndrome or oral allergy. Why does that occur? it occurs because of strange freaks of nature. There are a lot of foods that share antigens or proteins with pollen. And the classic example, if you live in the Midwest, is ragweed. A lot of people are allergic to ragweed. And when they eat melon, their mouth will get irritated. The other one is latex. Latex sensitivity involves cross sensitivity with tropical fruits like kiwi, mango, papaya. And one vegetable, you'll never guess what that vegetable is. It's bell pepper. And it's just a strange freak of nature. And so you're sensitized to the pollen. And then when you eat a food that's related or has a shared antigen, then your mouth will break out and get a little itchy and it stings, burns a little bit. That kind of allergy, Benadryl really is the drug of choice. That kind of allergy, you want to use liquid Benadryl. I even have my adults use liquid Benadryl because it coats the mouth and it kind of dampens down that reaction. I have the same problem myself. I have, I'm living with nightshade allergy. So my mouth will oftentimes burn and feel funny when I eat tomatoes or eggplant, which is also in the nightshade family. And if it gets really bad, I'll suck on an ice cube or I'll take Benadryl. So in that kind of sensitivity, pollen food syndrome, Benadryl really is the only choice. And actually, EpiPen doesn't even work for that. That is strictly antihistamine. There is another kind of reaction. I hope I'm not confusing people. These are people who are allergic to transfer proteins, they're called transfer proteins. How many have you ever heard of people who say, I can eat an apple as long as I peel it? And I'm also allergic to nuts. That's also an oral allergy. And this particular kind of protein lives in nuts and seeds and the skins of fruit. So if people peel the fruit, they can eat it okay because they're allergic to that. But if they eat just a raw apple or a peach or any kind of stone fruit, they again will have oral allergy. Again, you have to be aware of that, but Benadryl works great for those kinds of reactions as well. I hope I'm confusing people.
No.
No, and I'll write all this down, listeners. So don't worry about holding it all in your brain. You'll have it in our show notes on our website. It will all be hooked up and linked up for you to check out. So don't worry about that.
Can I ask you, can we go through for parents what the steps are? If you suspect that your child has an allergy and you are going to take them to an allergist, what can they expect at the office or as far as allergy testing goes?
Okay, I can't emphasize this enough. Always start with your primary care physician. In most cases, it's a pediatrician. Pediatricians are very aware. I mean, this makes up a large part of their practice. And pediatricians are equipped to deal with it on their own as well. But when they suspect an allergy and they don't feel comfortable dealing with it, then they will send it to a specialist. And the key for any specialist is to take a very detailed history to determine whether or not this is a sensitivity or a true allergy. The other thing that the specialist will spend time with is get a good family history to see what the risk factors are. Because there are children who are at risk because of their family history and children who are not at risk. And look at their past medical history. Have they wheezed? Have they had eczema? Have they had oral allergy? This is what a sophisticated allergist would do. And then the allergist will confirm their suspicion, only confirm their suspicion by doing testing. Testing, there are basically two tests right now that allergists do. One is an allergy skin test, where they put a little bit of what they suspect the offending agent is, do a little prick test, usually non-traumatic for children. And if they react, it'll get red and itchy in the office within 15 minutes. So that's called the prick test. There are intradermal tests, but we don't usually do intradermal tests for foods. The other test that allergists will do is a blood test, where we look to see if there's any specific IgE antibody directed against that food. And that's called a food-specific IgE test. Any lab can draw the blood and run that. We usually get the answer quickly because, you know, it is kind of an emergency situation. And we usually get the answer back in 24 hours. I always call my patients myself and talk to them about those findings. Now, there is what I call a second or third generation test. It's a very sophisticated blood test where we can take any suspected food practically and break it down into its different molecules and see which IgE is directed against that particular molecules. And the classic example for that is peanut, because we know a lot of children will have a positive skin test to peanut, but they eat the peanut and they're fine. So what's going on here? And what's going on is they made a cross-reacting antibody that, for instance, is directed against pollen, and will give you a positive test, but it's not a true positive test. And that's where it takes a little bit of sophistication. On the other hand, there are definite molecules that cause anaphylaxis and risk of future reactions. Those are called the storage proteins, high risk molecular components. For peanut, it's called ARA2 and 6. There's one for hazelnut, there's one for walnut, Brazil nut, and cashew. I can tell you what they are, but you'll forget. And I forget. I always have to look at a chart as well. So when we see a child who has a molecular test against the storage protein, we get very concerned about that for two reasons. One, they're at risk for anaphylaxis. Two is they may not outgrow it. It may persist throughout a lifetime. Now, the other reason why these molecular components are so important is because they don't get destroyed when you cook the food. You know, there's when you cook it, it's fine, like baked eggs for children with egg sensitivity. However, these storage proteins, even if you cook it, they're not changed. They still can cause an allergic reaction. And they're also stable for acid digestion. When we eat a food, our stomach acid destroys it and makes it so it's not allergic. But stomach acid does not destroy storage proteins. So even after you eat the food, you can still have an allergic reaction to it because the acid hasn't changed it at all. And that brings me to another topic. A lot of times people get concerned because they've eaten the food and continue to have reactions for days. And what's happening there is that food, unless they vomited right away, has stayed in their body. And so it's kind of stimulating the immune system for 2 or 3 days before the entire reaction goes away. And if that's the case, then we have to add a third drug, and that's a steroid. So steroids prevent that ongoing reaction that we would expect from any food that somebody has ingested but stays inside them for a long period of time.
And that's something that a doctor would give, like a prednisone or something, right?
Right.
Okay.
or an emergency room.
Emergency. That's what we had to do when we went to the emergency room. They gave Benadryl and prednisone.
Yeah.
And I think that the thankful thing was that it was such a small amount. I mean, like the smallest amount of egg had caused this. I am grateful it wasn't more. I would like to talk. You mentioned about growing out of allergies versus there's the potential that they won't grow out of allergies. Okay, so for example, my child who has this very severe egg allergy, when we had first looked at the numbers, they said, well, 80% of children outgrow allergies. So at least statistics are on their side, or on his side.
Right.
And then, like I said, things are so variable, right? So we do these tests in the allergy office, every few months or something, to determine if things have changed in one direction or the other, whether something's become more severe or less severe. And with Hunter, for example, it's becoming more severe. So how does that work? Because I still hear so many people saying to me, oh, he's going to outgrow it. He's going to outgrow it. Can we touch on that? Like, what determines if somebody's going to outgrow an allergy or not? And what are the clues? I know you kind of just already talked about that, but I just want to go into this more because it's such a conversation I have with so many people who go, oh, he's going to outgrow it, right? And there's no guarantees, right? There's no crystal ball.
No. Well, you kind of alluded to this in your opening sentence when you said that 8% of children have food allergy, but only 4% of adults. What's going on there? Well, yeah, people are outgrowing their allergy, but we're becoming more and more sophisticated now in breaking these allergies down into their molecular components. Egg is the perfect example. So for egg, you can make IgE to ovoalbumin, which is in the white of the egg. And if you've only made the IgE to the ovoalbumin, you have a pretty good chance of outgrowing it. However, the bad guy is the ovomucoid that's in the yolk of the egg. Excuse me, I told you I told it backwards. It's in the white of the egg. And if you've made an allergy antibody to the ovomucoid, that one has not as good of a prognosis. And that one you may not outgrow. Now, the other thing is ovomucoid is heat resistant. So in that case, you can't have any egg at all. However, if you've made an IgE reaction to ovoalbumin and you bake the egg, it becomes denatured with heat. And when we talk about heat, we're talking about heat. We're talking about baking an egg in a muffin at 300 degrees for at least 30 minutes. So that's the minimum required to break it down. And if that's the case, then you can eat baked eggs. And we actually recommend that for people who are allergic to ovoalbumin. And by actually eating the baked egg for a period of time, you can actually lose some of that sensitivity. So baked eggs is kind of therapy in terms of reducing sensitivity to egg for some people, not all people.
Yeah, be very careful with that, to work with your allergist for that. Don't just to say, oh, I'm going to test it and see, I'll give him a crumb or something like that, because it's so dangerous. Right. It's so dangerous.
I'm sorry. I didn't mean to make light of that. We do it in our office. We have people make the muffins and then come into our office. We give them very small amounts and gradually increase it to large amounts. So that's called oral desensitization. And that is possible with some foods, but not all foods.
Can you talk about the challenge though in your office? Like, let's say somebody has they do the skin test for hazelnuts, for example, I don't know. And the skin test comes back positive, they have a hive, but then the blood test says, oh, it's not serious, it's negative in the blood test. So the allergist is faced with, well, is this an allergy or not? And we're going to test it. What does that test look like? What should a parent expect?
Okay, so this is actually what I was talking about. So we're talking about hazelnut now, and it has different molecules, and we can do further testing and break it down into its various molecules. This is where it gets a little confusing. And the molecule that is the bad one in hazelnut is called core 9 and core 14. And these are molecular designations. If you make an IgE to that molecule, you probably are really allergic to hazelnut and you shouldn't eat it. Now, and it may last a long time, maybe even a lifetime. Now, so this is called molecular diagnostic testing. It's the next generation of testing. And these are the kind of tests that if you test for whole hazelnut, you won't know it, or even skin tests, you won't know it. You really have to do the molecular component testing to be able to really make a firm diagnosis. Why is hazelnut so important, by the way? Well, for years, we didn't have Nutella in the US. Nutella has been introduced fairly recently. When I was growing up, hazelnut was never a problem because nobody ate it. Now everybody's eating it because of Nutella. So it's become a big problem. Of course, it was always a problem in the UK where they use a lot of hazelnut.
So I think what I want to touch on is, so for these challenges, what we've experienced is we go into the office and let's say it's hazelnut that we're going to work with. We have to bring a pure hazelnut butter. You can either make it at home, or I had to go on Amazon and find, they're so expensive, hazelnut and pistachio and stuff, because they're just not that common, and you need it to just be the pure nut. And first, I believe they do a smear test on the lips sometimes if they're really worried about it. But they started with just a bit of, and at the same time, when they're giving this and your child is eating it, they have, if they're really young, they have them hooked up continuously to the oxygen rate monitor and heart rate monitor. If they're older, they just come in every so often and they check it, and they gradually increase the amount. So basically the goal is to get, and correct me if I'm wrong, Dr. Liebhaber, but the goal was to get like to 1 teaspoon per challenge. For hazelnuts, we were able to get there. At pistachios, we had to stop at 1/8 of a teaspoon because he was having a reaction. And that's how you can see, you do a little bit at a time, and it's in the office and it's in a protected setting so that if something does go wrong, if you're having a reaction, they can either administer Benadryl or an EpiPen as needed. So that's the challenge. But what I'm also curious is, I know that there's infusion clinics, right? So what I was told, and I'm still trying to wrap my head around all of this, is if a child has an allergy, they can do at a certain number of what it's safe, you can do a challenge in the allergist's office. If it's no longer safe enough to do that because the allergy is more severe, then we have like an infusion clinic, which I don't know if people actually do or not. You can touch on that. And then past that, it's like, don't even like, because Hunter's numbers are so high off the charts that you can't even think about it for like an infusion clinic, and you just have to keep that allergen at like a 2-foot radius at all times. So I just wanted to talk about that, like the seriousness of it and why certain challenges are done that way.
Well, again, we're getting a little more sophisticated.
Sorry.
Looking at the molecules, and some are just so risky. Any kind of exposure, it's too risky for children. Infusion or oral or whatever. I like the oral challenges, which I do in our office, because we do evaluate risk and we do look at risk versus benefit. Let's face it, there's some foods that you really don't need and have a very low risk of exposure, and others that you might get exposed to, like for instance, peanut in the classroom. So it doesn't matter if it's infusion or if it's oral or whatever. If you're at high risk, really high risk, we wouldn't do anything. We would just recommend avoidance and maybe even wearing a MediAlert bracelet, and certainly let the schools know. So we're very careful about oral challenges, and intravenous challenges we don't do in our office. Because let's face it, when you eat a food, you're not eating it intravenously, you're eating it orally. So that's the real key.
Thank you
To
for clearing that up.
clarify what I'm hearing, part of the therapy almost for allergies is tolerance as a child develops.
Right. And you can it'll either happen naturally or we can create it in the office.
Right.
Peanut is the classic example. For peanut, we're really not immunizing children against peanut. We're just developing a tolerance for maybe small amounts, but that's good because that means, they're accidentally exposed in the classroom. They're not. By the way, for peanut, we introduce it with the smear and a little bit more and more. And then you have to continue it or you lose your tolerance.
Mhm.
And in that case, you have to continue actually eating a little peanut, maybe 3 times a week, to maintain that tolerance. So it's not a one-off thing, it's a continuous thing.
And so when I was pregnant, I ate a ton of peanut butter with my first child, and now he loves peanut butter. So does the pregnant mother have anything to do on the outcome of her child's allergens as they develop?
Probably not. Those intact peanut proteins don't
Okay.
cross the
Yep.
placenta. By the way, they don't even hardly come across the breast milk either.
Okay. Okay.
And breastfeeding,
Interesting.
if you do have an allergic predisposition, I highly recommend it, no matter what you're eating.
Mhm. Okay.
Dairy may be a little different, but remember, you don't have to drink a lot of dairy to make breast milk. I mean, cows don't drink dairy, and they make
Right.
good milk. So, yeah, you can get by.
Okay.
Yeah.
And what do you think about those allergen powders that are available these days? I've seen a lot of those advertised now. I'm curious about your opinion on that.
Well, again, I always say kids don't try this at home. If you think you're allergic to something, don't do the allergy powders. I will say this, and this goes back to that Japanese study I quoted at the very beginning. There are a bunch of formulas that are not pure dairy formulas. They're what we call hydrolyzed formulas. In other words, these formulas take the dairy and break it down into its individual amino acids and don't sensitize the baby. So I'll name 3 of them. I guess I'm allowed to name some names. Similac Alimentum is one, Nutramigen is the other, Progestamil is the other. They're readily available. You don't even have to go to the pharmacy, most of them in the regular food markets. And for children with dairy sensitivity, these are really good supplemental formulas if you are nursing, because they take the milk and they make it hypoallergenic, so it doesn't cause problems. So we use a lot of these hydrolyzed formulas for that reason.
Great. Really helpful. I'm at that stage now where we're doing a little supplementation with formula and still breastfeeding. And so all of this is very applicable to me right now.
Good. And, studies have shown, there are studies that show that breastfeeding doesn't protect against allergies. However, if you look at those studies very closely, they didn't actually determine how long the baby was breastfed. Could have been weeks, could have been 6 months, could have been a year. But if you look at those babies who were breastfed for a year, they did have a lower incidence of allergies. So breastfeeding is important, but the longer you breastfeed is even more important.
Okay. And then what about the at-home food allergy tests? Are those helpful? Are they reliable?
Yeah, I am not familiar with, I have to admit ignorance there. I'm not sure what they're actually testing. I'd have to look into that. I just won't really have an opinion on it because I don't know what they are. And actually, I never even heard of them until you mentioned it on your program.
Sure, yeah. So I have a few other questions for you. One is when it comes to parents going out to eat at restaurants, how do parents with these difficulties kind of prepare for that or make requests? Because now we're talking a little bit about the social effect, I guess, of allergies, right? And how this can be frustrating for the restaurant or whatever. It's like, don't put the shrimp on the chicken and don't blah, blah, blah on the grill. And people get really uppity sometimes, in a restaurant environment. So how can parents prepare for this kind of a scene?
Well, you got to call ahead and ask.
Mhm.
But I'll caution you about that. I've been in practice long enough, so I've seen really crazy things. And I have a patient, an adult with peanut allergy, who went to a restaurant, I won't name the restaurant, and asked the waiter, she ordered a pesto pasta. And she said, is there any peanut in the pesto sauce? And the waiter said, no. So she ordered the pesto pasta, sound familiar? And ate it and had an anaphylactic reaction in the restaurant. They had to call. The cook came running out and she said, I asked you, you said there was no peanut in the pastas, in the pasta sauce. And the chef said, well, that's true. However, I grind up peanut and put it in the pasta to give it a kind of a nutty flavor. Well, she didn't think of asking about that and ended up with, so accidents happen, no matter how good the restaurant is and how secure you feel. Now, the other situation in children are the schools. And I got to tell you, here in our local area, the Santa Barbara schools, the Goleta schools I consider them safe and secure. Very good, they're very attentive. They take food allergies very seriously. There's a form you fill out when your child starts every year. I know about that form because I filled out about 100 last week. And I don't mind filling it out. I think that's fine. And it says what they're allergic to, what they need to avoid. If they feel that they can't deal with it, they will insist that the child bring their own lunch to school. They're very careful about what's being brought into the classroom. And I feel very comfortable with our schools. I think we have a good system. I play this little game with children, especially toddlers and older children. I give them scenarios and I say in my office, now, what if you're in school and a little friend of yours has a birthday party and the mother brings in cookies? What do you say? And I tell them to be polite. And they say, well, are there any peanuts in this cookie? And I said, that's the right question. You're asking the right question. And if the mother says yes, what do you do? And they say, we won't eat the cookie. So you have to kind of play these scenarios with your children when they're in school. So they understand, because you were right at the very beginning, Jessica, you mentioned that some parents just don't understand about food allergies and aren't adherent to restrictions. However, the schools are getting better and better at that all the time. I see fewer and fewer accidents. Having said that, I will say this, you're kind of on your own. Most schools in our area do not have a school nurse. They may have one per district or two per district, and they wander from school to school. So there's not good nursing supervision at any of our schools anymore. But most teachers in schools are pretty attentive.
Just to add upon that, to build upon that, sorry, parents also be aware of birthday parties, right? So even if your child doesn't, let's say, eat cake because the cake has egg in it. You know, you have to be careful if the children who do eat the cake or the cupcakes go and touch them or kiss them or play with the toys and all those different things. And I know that seems so neurotic for other parents who have no experience with that. That's a challenge for us going to birthday parties, for example, because the slightest thing, if let's say, you know, Susie eats a cupcake and then goes and is all huggy on Hunter, I mean, it puts him in a very dangerous situation. So it's very, it's an uncomfortable social aspect because you don't want to be this like neurotic parent. And sometimes too, the kids are too young to explain, oh, I can't eat this, or oh, I can't be around that. So just, I think that's a huge thing for me to just request of other parents to just be aware of that because we're all trying to protect each other.
Right.
Yeah, absolutely.
Not to make you paranoid, but another case comes to mind where I have a child with peanut allergy, and he touched another child's peanut butter and jelly sandwich. He didn't eat it. Then he just touched it, and then he rubbed his eye, and he exposed that way. His eye swelled.
Right.
Thank goodness that's all that happened. But strange things happen. Yeah. So
Can I add to that? I had an experience where we were at a restaurant. We kept Hunter in his stroller. I fed him certain food. I kept everything away. And this one lady came up to talk to us, and I do a really good job typically of like keeping him away, even though I feel so rude, but she went and touched his little hands. And right away, I wiped his hands off, but they were just water wipes, you know, boom, hives. I mean, he touched himself somewhere. And so, you know,
sure.
just keep in mind that some kids are very sensitive. Even if you touch a plate with a peanut or something and they have an allergy, and then you touch the child, it all plays into effect. And I feel like people look at me like I'm crazy all the time and like, wash your hands, or wash your mouth or whatever. Don't kiss him. But it's so dangerous. So I'm just pleading, please.
Yeah.
People have some boundaries, right? Like
yeah, I totally
take a step
understand.
back.
Yeah. Yeah, absolutely. By the way, I forgot to mention as you were talking, very important for toddlers to be fed in high chairs or secure environments. So many times I see children, they're allergic to the food, but they walk around with a little something in their mouth and they trip and they fall. They take a big breath and they aspirate that food. And that's a dangerous situation because that's an emergency situation in which the child needs to be admitted. Somebody has to do a bronchoscope and fish that food out of their airway. So that's another very dangerous situation. Children should not be allowed to wander around with food in their mouth in case of that scenario happening. So sit in a high chair, sit in a secure seat, and eat that way, and don't wander around with food in your mouth.
Great advice.
So I have kind of a zoomed out question. I don't know. I'm curious just if you have a perspective on this, but okay.
Sorry.
So I'm just curious if you know anything about this in regards to if there's anything we can do with sustainable food efforts or farming practices that has an effect on, you know, how the foods are actually harvested and then put into the body.
Well, that might explain some of the increase we've been seeing in food allergies. I don't know. But sometimes this GMO restrictions work against us. And I'll give you an example. Peanut is a classic example. So peanut has a particular protein called a storage protein. It's called an S2 albumin. And that can be genetically removed from peanut. So they can grow a hypoallergenic peanut, but they can't do it because we have restrictions on GMO. That's a case where our restrictions on GMO have made the problem worse. So hopefully someday we'll be able to make some compromises and maybe farm foods that are hypoallergenic. Wouldn't that be wonderful?
Interesting.
Wow. I never even thought of that. That would be incredible.
Yeah.
My last question, and it has to do with foods, is can eating other foods help with allergies? Like, for example, I know for egg allergies, if you have a certain probiotic, which happens to be found in Stonyfield yogurt, it's that, gosh, I forgot the name of it. But I know that because there's not much we can do for the egg allergy, by feeding him this particular probiotic, it can help the gut biome and something to do with that. Does that apply to nuts? Does that apply to all allergies?
It might. I mean, the final word isn't in. And maybe that might explain why we're seeing more food allergies, because the microbiome has changed a little bit over time. That's the real advantage of nursing, is you create a very acceptable microbiome in the child's gut based upon your lactation. So yeah, that's something that we need to look at and might explain this burgeoning food allergies that we're seeing. But on the other hand, I am a firm believer that food is for nutrition. I don't think of food as medicine. I don't think that you can eat something and protect and treat a medical illness because what you're eating. Food is strictly nutrition.
And do you have
Love it.
anything else?
No, I think we covered everything we wanted to today.
I feel like this has been so incredibly helpful for somebody who is not well versed in the world of food allergies, and somebody like me who's in the thick of it. I feel like you really took a comprehensive approach, and I cannot thank you enough for everything that you've shared, truly.
Thank you very much for having me on. It's been a pleasure. I hope I was able to talk about the conceptions, but also the misconceptions.
Yeah. So when we close every episode, we talk about a tip, a product, resource, anything that has helped us personally on our parenting journey. So let's go ahead and do that. Angie, do you have anything that you'd like to recommend?
Yeah, so I just ordered these really super soft Life Tree baby washcloths, and they can be used for just wiping baby's mouth or for actually a bib. So I love the efficiency of the product, and that's mine for today.
Awesome. And Dr. Liebhaber, do you have any additional resources you wanted to share?
Yeah, there is a great organization for people who have children with food allergies. It's called the Food Allergy Network. They're a wonderful resource. They have recipes, all kinds of ideas, and they do a lot of advocacy in terms of legislation. Because of them, we have these label warnings. They really do good work. That's the Food Allergy Network.
Excellent. And we'll link that up on the website and everything on our show notes, everybody. So yeah, if you don't know about our show notes, go check it out on our website, informed-mom.com, because we always want to have extra resources for you guys to go back to. For me, my resource or my thing to recommend, I recently watched on Netflix the Rotten documentary, and they have an episode on peanuts and food allergies. And I found that a friend of ours had recommended it. And I found it fantastic. I mean, I just thought it was so great. And I really want to recommend people watching it for if you have food allergies, or even if you don't, because I feel like it was so helpful for parents, for everyone to know. Everyone needs to watch this. So that's my recommendation. All right. Well, thank you again, everybody, for joining us. This has been super informative, and we hope that you follow us on social media. We're on Instagram, we're on Facebook at Informed Mom Podcast. Like I said, our website is www.informed-mom.com. We love hearing from you. So if there's ever a topic or anything that you want us to dive into, please shoot us an email, informedmompodcast@gmail.com, or just shoot us a message online. So thank you, everyone. We really appreciate you joining us today.
Thank you.
Thank you.